New York. And good morning, good afternoon. My name is Tracy Cook, and I'm with Saks Healthcare Communications. Before I introduce our moderator and speaker, on behalf of Medtronic and Saks Communications, we want to thank all of the frontline workers in our audience for your commitment and passion in helping us all through this very difficult time. We are truly indebted to you. Also, this webinar is being provided as a demonstration of our support for respiratory therapists. Today, you have the opportunity to hear this webinar in either Spanish, Portuguese, or Mandarin. To do so, please open a Chrome browser, not an Explorer browser, and type this link into the browser. This link is also posted onto the chat box. Next, you'll type in the password #GoTo1 and then select Spanish, Portuguese, or Mandarin. Step 2, please mute yourself on the GoToWebinar toolbar. You'll find the toolbar at the top of your computer. Just right-click and mute site. You should now only be able to listen to the translated version. For today, you can submit questions using the questions box. We will try and answer as many questions as possible at the end of the session. Our moderator for today is Fernando Yusti. Fernando Yusti is a Senior Global Principal Training and Education Specialist at Medtronic. He has over 20 years of international experience in the medical device industry with positions ranging from management, sales and marketing, product development, clinical affairs, and business development. Dr. Yusti holds a PhD degree in physics from the University of Madrid and an MBA marketing specialty from ESADE Business School. Fernando, welcome.
Thank you very much, Tracy, for that kind introduction. Today, we are going to have the honor of listening to Dr. Ashish Khanna. Ashish Khanna is Associate Professor at Wake Forest School of Medicine. He's also an anesthesiologist and intensivist at the Wake Forest Baptist Medical Center in Winston-Salem, North Carolina. Dr. Khanna serves on several editorial boards, including the Journal of Critical Care and the Annals of Intensive Care. He has published extensively in peer-reviewed journals on several perioperative topics, including opioid-related respiratory complications and the prediction of and monitoring for cardiorespiratory complications within and outside the ICU. We also have with us Dr. Bull. Dr. Bull has been a nurse for over 16 years and recently completed her doctorate in education. Her clinical areas of expertise include pediatric and post-surgical nursing with a research focus on adherence to evidence-based practice and airway management. Katie spent many years teaching in undergraduate and graduate nursing programs before coming to Medtronic in 2017, joining the Medical Affairs Department. The faculty disclosures are that Dr. Khanna is a consultant for Medtronic, and also he belongs to the steering committee of the Prodigy clinical trial. As said before, Dr. Bull is an employee of Medtronic belonging to the Medical Affairs team. Today's event is going to be giving you 1 hour of continuing education if you are a nurse, an EMS professional, or a respiratory therapist. At the end of this event, we will share with you how you can obtain your CE by going to a certain link. With that, I want you to join me welcome Dr. Ashish Khanna.
Thank you, Fernando, and welcome everyone. I appreciate you all joining us today, sparing time out of your busy schedules to talk to us and discuss more about ventilator-associated pneumonia. We've done a preliminary talk about this a little bit ago, and this is a follow-up, and we will be advancing education as far as ventilator-associated pneumonia is concerned today. and in more webinars to follow. These are some of my learning objectives. I will start by describing some of the tracheal tube anatomy, as I call it, with specific focus on the tracheal tube cuff and the pathogenesis of ventilator-associated pneumonia. I will define and describe other strategies focused around tracheal tube architecture and ventilator-associated pneumonia. And then I will also touch briefly upon the role of subglottic secretion drainage at the bedside. And then I'll hand it over to Katie Bull, my co-speaker, who's going to take a deeper dive into some of these areas. This illustration and nice little figure here clearly sort of explains the heart of the matter. Focusing on the center, we're looking at pathogenic factors that build up to cause VAP. And on the right side of your screen, you see some of the prevention strategies. Let's look at all of these in a little bit of detail. And I'll be going through most of these in the slides that follow. In terms of pathogenic factors, our patients, when they're in the ICU, they're often colonized. Their oropharynx and nasal sinuses are colonized by bacteria. And all of that will also lead into the fact that secretions that pool down from those areas collect around and above the tracheal tube cuff. They're potentially then infected secretions. Tracheal tube cuffs do not necessarily provide a foolproof 100% seal that leads to microaspiration of secretions past the cuff. There could also be tracheal mucosal injury by the airway device itself, in this case the tracheal tube, that adds to the microaspiration issue. And then going further down the list here, there's always colonization of the upper respiratory tract that adds to the bacterial load around the tracheal tube cuff. Finally, there's also the luminal surface of the endotracheal tube that continuously forms a fairly resistant to antibiotics biofilm, and that adds a continual reservoir of bacterial dissemination throughout the respiratory tract. All of this means a perfect storm for ventilator-associated pneumonia. In fact, this is the gateway to ventilator-associated pneumonia in my books, and that's where this publication says all of this is leading to. Let's look a little bit towards prevention strategies as well. So there are things that we do as daily practice in the ICU that should mitigate some of these problems, right? So we encourage great oral hygiene for our patients. Hopefully, we're all doing our chlorhexidine 2% washes. Patients who are awake and conscious are able to brush their teeth. We're encouraging that as well. So that should take care of some of this colonization part. Subglottic secretion drainage, I'll touch upon that today. It's clearly essential once secretions start pooling around the tracheal tube cuff. I'm also going to touch on this. That's newer tube and cuff design and cuff pressure maintenance. Really important in sealing the cuff around the tracheal lumen and preventing microaspiration. And finally, what can we do to our tracheal tubes? We've designed some coated endotracheal tubes and tracheostomy tubes, and they should help with biofilm formation, colonization, upper respiratory tract. So there is mechanisms and preventative strategies to help us do better when it comes to ventilator-associated pneumonia. Let's start by talking about cuffs. The illustration here on the right shows two different kinds of cuffs. This cuff right here is a high volume, low pressure cuff. So typically a bigger surface area of contact with the tracheal mucosa, less pressure exerted on the tracheal mucosa means less microcapillary injury of the tracheal mucosa, less chances for tracheal mucosal erosion and formation of fistulous pathway here. So great from from that perspective, keeps the airway right in the center, and in general, like I said, minimizes tracheal injury, seals, and is supposed to seal the corners of the trachea pretty well. On the other hand, this is something that we don't use as commonly now, is a low volume, high pressure cuff, which does apparently put a lot of pressure on the tracheal mucosa, causes tracheal mucosal vascular injury and ischemic injury, tracheal erosion, and so on. The tube you can see with the asymmetric cuff pressure is herniating off to the other side. It's a setup for disaster, really, and that's why we essentially moved away from these kinds of cuffs. We used to think that the high volume, low pressure cuff is really good and provides a pretty foolproof seal, but we now know that there is formation of longitudinal channels here and redundancy channels within the folds of the cuff as it comes in contact with the tracheal wall. And these underinflated or asymmetric cuffs are a problem. It's also problematic because it's difficult to continuously monitor the position of the cuff, the redundancy of the folds of the cuff, and adequately monitor cuff pressures. All in all, which means that there is always chances of microaspiration, despite theoretically this cuff appearing to seal the tracheal wall really well. And there's been data to suggest that the role of the cuff is really important when we talk about ventilator-associated pneumonia. In fact, there's a role for cuff pressures when they drop to less than 20 centimeters of water. It increases chances of microaspiration. And number two, there's been seen, at least in some of the studies here that I'm quoting, nearly 90% of intubated and mechanically ventilated patients will have some amount of pepsin in their tracheal secretions. Pepsin is a enzyme that usually originates in the stomach and the upper GI tract. And it being found in tracheal secretions clearly means that GI content has made its way into the airway, which is never a good sign. So if cuff pressures are that important, can we just, put everyone on some sort of automatic cuff pressure controller and help out? Well, apparently data is pretty inconsistent. So in trials that have used automated cuff pressure controllers to control cuff pressures about 25 to 30, or intermittent 8-hourly bedside nurse adjusted cuff pressures, versus just standard manual checks and correction of cuff pressure only if it's low, have not seen really a consistent difference or improvement in outcomes. So while again, theoretically cuff pressure controllers or more intensive cuff pressure control seems great, however, outcomes data is more or less lacking in this matter, or at least lacking and consistently pointing to a certain direction. Here is an illustration of what is going wrong. These are 5 different high volume, low pressure cuffs, the kinds we use all the time for all our endotracheal tracheostomy tubes, and all of them demonstrate. So this is the area where, imagine these are subglottic secretions that are collected above the cuff. Look at all of them. They've all collected secretions here, and almost all of them have some sort of leakage on the other side. This should not be happening with your patient, but likely is happening all the time. And really, no two cuffs are the same. So if you look across here from A to E, different cuff shapes, profiles, and trajectories, and different distances from the end of the endotracheal tube. Again, different performances on a leak test for subglottic secretions. Apparently, cuff A and B haven't done well at all. They've leaked almost all of what was collected in the subglottic area, but cuff C, D, and especially cuff E has done really well. This is a low cuff, really low and near the end of the endotracheal tube. And this is a cylindrical cuff that's also doing pretty well in this matter. Let's take a deeper dive into some of this. So there is something called the low volume, low pressure cuff, in which functions on a tracheal tube right like this. It has a single working intracuff pressure that's actually really high. It's 80 centimeters of water. But the great thing about the low volume, low pressure cuff is that though the intra-cuff pressure is really high, what it transmits to the tracheal wall is kept to a very desirable level, about 15 22 millimeters or 20 30 centimeters of water, which is all very much in line with tracheal mucosal safe pressures. It also automatically is able to maintain a constant elasticity within the cuff wall. It effectively then protects the tracheal wall. There is no redundancy folds within the cuff wall that would allow fluids to pass through and hence no leakage. Holds much more of a fluid column above the 30 centimeters of tracheal wall pressure compared with a standard endotracheal tube. And also, I'll be talking more about this. Right around the area of the cuff, there are 3 subglottic suction ports and a automatic cuff pressure controller. So really neat device and apparently is pretty helpful. Let's take a closer look at other kinds of cuff. So here is a elongated cylindrical shaped cuff, and I'll be talking about cuff materials later on. This one is made out of micro-thin polyurethane, which is a better material than standard PVC cuffs, and a fully inflated cuff in situ has only minimal excess cuff material. So you can look at this, fairly smooth, no redundancy, and at acceptable intra-cuff pressures of 20 to 30 centimeters. So no channel formation. Shape of the cuff also results in a larger contact area with the trachea and a significant reduction in leakage with this low volume, low pressure cuff variant, which is shaped in the form of a cylinder. Let's talk about cuff profiles. So the conical or the tapered cuff is something that has been seen to be useful, or an inverted pear-shaped cuff is also what we call it. It has better sealing properties across a wide range of tracheal diameters when compared to the standard cylindrical cuff. Here is a closer look at it. Conical cuff also has a subglottic secretion drainage port right here. And even closer look at it, it has a hooded Murphy tip and eye. It has depth markers and a tip-to-tip radiolucent line. This is how it looks like on cross-section. Has a nice sealing band over here. Minimal cuff creases, if anything at all. And then if this kind of seal is provided and the cuff creases are not going to be a problem, then hopefully microaspiration will not be a problem. And most of the data supports that. Cuff material, like I said, is really, really important. So compared to a 50 micrometer polyvinyl chloride material, the very thin polyurethane material, only 7 microns, is really beneficial. And beneficial because the more thinner this material is, the less chances of folds and channels and less chances of microaspiration. And clearly data proves that. There is, for example, a reduction in VAP from 5.3 to 2.8 per 1,000 ventilator trays in some of this data shown here. And then there was reduced leakage demonstrated as well, except when the patient was on at least 15 centimeters of PEEP to prevent that leakage. Now remember, when you add PEEP, you actually prevent leakage. But on the other hand, you don't want to add PEEP to your patient's ventilation strategy just because you want to prevent microaspiration. Mostly we're keeping PEEP around 5 centimeters. So clearly you don't want to push PEEP up to 15 centimeters for a patient just because you want to prevent leakage. And that's where these cuffs are now really beneficial, because they sort of give you a ventilatory independence as a critical care doctor, and hopefully no issues whatsoever when you develop a ventilatory strategy for your patients. Again, going into depths of the cuff material, a polyurethane cuff here has been shown as a taper-shaped cuff and also has a retracted tip. So this retracted tip helps with nasal intubations, less traumatic when going through the nares, and has an incorporated Murphy eye. Again, a really neat feature, along with a nice tip-to-tip radiolucent line for visibility on chest x-rays. Let me talk about subglottic secretion drainage, though. This is really the heart of the matter, and this is really the heart of the issue of ventilator-associated pneumonia. Whatever we are doing, designing cuff material, designing cuff shapes, designing subglottic secretion drainage mechanisms is all to take care of this area right here, is pooling of subglottic secretions that are coming from a highly infected oropharynx and nasopharynx, and some of them also regurgitating back from the stomach. And we have to absolutely seal and protect the downstream airway here, and we have to develop a mechanism to remove all this in a safe manner for our patients. The other issue is also that the longer you keep your patient intubated, the more there is impairment of mucociliary clearance of secretions with patients being just laying in supine, or even if they're 30 degrees up in bed. It's not like the awake patient who has the ability to cough out secretions, and that's where all of this becomes a huge issue in the pathogenesis of ventilator-associated pneumonia. How does subglottic secretion drainage works? This is a prototypical endotracheal tube pilot balloon, and this is a subglottic secretion drainage port. Typically incorporates itself into the outer wall of the tracheal tube and opens up right here, right above the cuff, and some kind of suction pressure can be applied here to effectively clear out this area. Data has shown about a 50% reduction in the incidence of pneumonia, more benefit for patients who are intubated for longer periods of time because there'll be more collection of secretions here. Reduction in length of mechanical ventilation ICU stay by 2 or 3 days, which is huge when you look at the cost of single day in the ICUs, at least about $4,500 to $5,000 at minimum. This means a lot when you look at an entire hospital system, how much money that hospital system stands to gain. And then truly a part of VAP prevention bundles now. And the issue, as my co-speaker will talk to you more about, is not just having a subglottic secretion drainage port, but knowing what to do with it. Quite often I've seen tubes with subglottic secretion drainage ports, but no one really using them or knowing how to use them well to best benefit their patients. And this is a deeper dive into subglottic secretion. It typically, like I said, is adjacent to tracheal tube cuff, but importantly, it should be away enough from the tracheal mucosa. When you apply suction here, mucosa should not get sucked in here and cause tracheal mucosal injury. When you combine it with a conical or tapered cuff, as you inflate the cuff, this tends to move away from the tracheal mucosa, and it adds an additional layer of safety along with the better seal that a conical cuff is providing you. Hourly intermittent suctioning could be recommended instead of continuous suctioning through these. It's always nice to have more than one subglottic suction port because one might get blocked or might not be right in the area where pooling is occurring. And remember, tracheal tube outer diameters will increase by approximately 1 millimeter when you have these kinds of mechanisms in place. And some folks are concerned for laryngeal edema and tracheal injury, but in my books, if you do an appropriate tracheal tube selection and you're cognizant of the fact that outer diameter tracheal tube is 1 millimeter more and intubate the trachea atraumatically, there is really no clinical concern that I have seen personally in my clinical practice with using these kinds of endotracheal tubes. So what else? So there can be secretions collected around the cuff, but remember the luminal surface of the endotracheal tube is not necessarily the world's prettiest place either. These are real, microbiological films that have formed, 40 micron films in this case, and real images taken from the luminal surface of endotracheal tubes within days of intubation. This kind of layer of some nasty bacteria starts forming on inside of the endotracheal tube, and then they serve as a constant reservoir for bacteria dripping back down into the airways. And I sometimes wonder how our patients are getting away with things like this, and it's unfortunate that we have the ability to see this, but we're not coming back stronger with measures to actually prevent this from happening. So what can we do for bacterial biofilms? Like I said, they form on luminal surfaces of endotracheal tubes, and within hours of tracheal intubation, mostly abundant at about 4 days out from intubation, huge reservoir for pathogens. 70% of patients with VAP had an identical pathogen isolated from the insides of their tracheal tube and lower respiratory tract. Clear evidence that that's where they're originating from. They're very much multi-drug resistant. But there is now the coming up of antimicrobial silver hydrogel ET tubes that have shown delayed or reduced bacterial colonization in certain ventilated animal models. So more and more, we should be moving towards endotracheal tubes that have in them the ability to prevent biofilm formation. So there's other studies as well. Here's one more study. It was called the Nascent study. It randomized 2,000 patients in a multi-center prospective trial, intubated them with either a silver-coated tube versus standard, and showed a statistically significant relative risk reduction of nearly 36% for the occurrence of VAP in patients who got the silver-coated tubes. There was no reduction in the length of mechanical ventilation, ICU stay, or mortality. However, I think nearly 36% reduction of VAP means a lot, and VAP rates were definitely lower than previously quoted rates, 5 to 10% versus usual 10 to 20% in this study. So a nicely done randomized control trial is showing a reduction in VAP rates. I've shown you the images in the preceding slide. I think it's incumbent upon us that we do what is best practice for our patients, and especially for the patients that we know are going to be intubated for 4 or 5 days. They are absolutely that cohort of patients that are, if they're not going to have problems because of their primary illness that brought them to the ICU, they're going to then have problems because of ventilator-associated pneumonia, secondary to subglottic secretions and biofilm formation. So where does the evidence stand overall as I come to the end of my talk? This is a very, very busy slide. And I will refer you all to all of these studies. There's tons and tons of studies that have stood for all of these preventative measures that I've gone through. I will not go through the depths and details of all of them. A lot of them right up here are subglottic secretion meta-analyses. There's a cuff pressure controlling, continuous versus intermittent control meta-analyses. Here's a cuff material multicenter RCT, another one for cuff material with a PEEP. There's another one for a polyurethane cuff. There's more for tapered cuff, now a silver coated tube, and other systems to clean up the biofilm. Again, feel free to take a deeper dive into these. Results here, by and large, suggest reduction in VAP. There's some studies that don't show significant impact like this one right here. However, what I want to tell you is that there is layers and layers of data that is out there that is pointing to either a substantial benefit or no difference at all, no harm whatsoever. And again, it's incumbent upon us that when we know that there is a high risk patient, we do the right things for our patient. We have the toys, we have the tools. It's only upon us how we best use our clinical judgment, and we use these tools for the safety of our patients in intensive care units. At this stage, I'm going to hand this over to my colleague, Katie Bull, and she will talk to you all about subglottic secretion drainage.
Thank you, Dr. Khanna, for that review. Now let's go ahead and let's dive into subglottic secretion drainage, specifically regarding its use. It's a newer bit of technology that can be a little bit daunting if you've never used it, or maybe you've only used it sparingly. I'll provide a high-level overview of SSD and how it differs from tracheal suctioning. We'll discuss more on the procedure, monitoring, and also troubleshooting. But we're also going to touch on some of the barriers of use to SSD technology. So without further delay, we'll go ahead and hop right into it. So first, subglottic secretion drainage, as Dr. Khanna has reviewed, is suctioning of the secretions that pool above the cuff. So here we see a picture of a tracheostomy tube. Dr. Khanna showed pictures of an endotracheal tube with subglottic secretion drainage, and they're really the same, just a different type of tube, but they work in both ways. They're the same. What I'd like to call your attention to in this picture is how the secretions and therefore the suctioning is outside of the primary tracheal airway. This seems obvious, but in my own research, I found that staff can sometimes have some confusion regarding this concept. This is a really important differentiation because unlike tracheal suctioning, there's no need to pre-oxygenate, there's no risk of decruitment because the suction is not impacting the airway as long as the cuff pressure is appropriate, which we're going to talk about more in a few minutes. But in this picture, you'll also see, as Dr. Khanna has pointed out, that suction notch right above the cuff. This notch allows for that drainage that's pooling above the cuff to evacuate up that incorporated evac lumen and then into the suction tubing, which you can't see here. The notch location is near the cuff. Again, that's designed, as Dr. Khanna alluded to facilitate that pool drainage evacuation, but also being close enough to that cuff to provide some distance that when the cuff is properly inflated, there's kind of that nice space between the tracheal wall and then the suction. And that's really intended to hopefully provide a little bit of that distance that will allow or prevent, I should say, the suction from getting too close to that mucosa. So now on with the procedure. The first things first is obviously your patient needs to be intubated or trached with a SSD compatible tube. Of course, you'll need suction tubing and a reservoir and then some type of suction apparatus, usually wall suction. But you'll also need to ensure that you have the proper cuff pressure. So a myometer will need to be used as well. If we use MOV or estimating cuff pressure by feel, that's not recommended because pilot balloons are not intended to be a determination of cuff pressure. Cuff pressure is really important because overinflation of the cuff can lead to tracheal ischemia, which leads to lesions, ulcerations, and a lot of other adverse events. Whereas cuff underinflation will allow subglottic secretions to leak beyond the cuff. So not only is this a risk for infection, as Dr. Khanna has talked about, but if the secretions are leaking past the cuff, there's no secretions to be suctioned out. So this really renders the subglottic secretion device null and void of any patient benefit. So hence, and I emphasize, checking cuff pressure routinely is key for safety and performance of the subglottic device suctioning. Next, of course, setting the suction. So this is just like tracheal suctioning. So we identify what the provider orders are, whether it's intermediate or continuous, and noting that proper pressure. Intermediate pressure should be between about 100 to 150 millimeters of mercury, or if you are using continuous, it should not exceed more than 20. Of course, follow your manufacturer guidelines and your facility guidelines, but make sure that the pressure is always set first with either a kinked or occluded tube before connecting, and then turn on. Monitoring the subglottic suction is pretty straightforward, but let's review just a couple of items first to align our expectations, especially if your only experience has really been dealing with tracheal suctioning, because there's some differences. So first, and to repeat, make sure that that cuff pressure stays within that Goldilocks zone, right? Not under and not over. Of course, you want to make sure to change the suction tubing per your facility guidelines. But here's something that is different. Subglottic secretion drainage, particularly in comparison to our normal tracheal suctioning, the amount will typically be very scant. So one study noted that patients may have as little as 2 milliliters of secretion that's pooled above that cuff, usually only making about 1 to 2 milliliters an hour. This is really important because if there's a misunderstanding or an assumption that the reservoir should have more secretions than what it really does, then one may mistakenly think that there's an occlusion or maybe that the suction isn't working. Again, this might not be the case if scant secretions are not always obvious, right? They can get stuck in the tube, or you may have an assumption that there's supposed to be more than what there really is. If an occlusion is assumed or if it's identified, it can be cleared. So you can always follow the manufacturer guidelines and of course your facility guidelines, but typically it can be cleared with either a bolus of air, usually about 5 milliliters, or a small bolus of normal saline. But let me be very, very clear and emphasize this point. When you are attempting to aspirate the bolus that we just put in, so whether it was air or more so with normal saline, do not attempt to aspirate the bolus or the occlusion with the syringe. Rather, we have to reattach the suction that has already been set at safe levels. So we've already talked about the maximum pressure that we really want to connect suction with is 150 millimeters of mercury. However, when we attach a suction from a syringe suction, you can create intense pressures of up to 4,000 millimeters of mercury in that tracheal space. So this greatly increases the risk of mucosal injury. So now that we've reviewed kind of the how-tos, let's look at the why nots, right? Or in other words, why aren't people always adhering to using subglottic secretion drainage? As Dr. Khanna noted, sometimes you may have the technology available, but the bedside providers and staff aren't comfortable or maybe are choosing not to use it. Although the SSD is recommended by the CDC in the United States and other organizations around the world, it is actually the least adhered to VAP task. As you can see here in a literature review that I conducted for another study, on average, SSD was only adhered to about 51.9% of the time. This includes patients only with SSD technology already in place. So this means that a patient that was intubated with an SSD compatible tube, the staff only utilized the subglottic secretion drainage suction half the time in comparison with other tasks that we see that are used to decrease rates of VAP, like hand hygiene, head of bed elevated oral care, even minimizing sedation was used and adhered to more than subglottic secretion drainage. So lots of studies have examined why this is. Why aren't people really using and adhering to subglottic secretion drainage if the technology is already available? There's specific reasons that have really come to light, particularly 3 that have appeared in literature. And these are a lack of knowledge, which we're addressing today, fear or perceived lack of benefit. So people don't believe that it maybe works, or maybe they're afraid that they're actually going to hurt the patient, or they're unclear as to whose responsibility the suction maintenance is. Is it the RN, the nurse, or is it the respiratory therapist or the physiologist? So the most complex issue here is really going to be that fear and that perceived lack of benefit. So that's what we're going to focus on here today. So let's quickly review this and navigate this fear. The fear of subglottic secretion drainage has been documented in lots of studies, and it's a strong barrier to the bedside providers from utilizing this technology. We fear that a risk of discomfort or maybe even the noise is disturbing to our patients. We even have a more specific fear that suction can cause that mucosal trauma. Well, to date, we still have a lack of significant data to really help us understand this. And of course, that also contributes to the fear of the unknown, right? So let's look at the studies that have been done, and we'll like we hear right now with our current pandemic, we're going to follow the science that we currently have. So we note one particular study by Lasharade, who cites several different articles on this topic. First, there's some human and animal studies that have been done to monitor and to understand what the impact of mucosal injury is using subglottic secretion drainage. But these groups are typically very small groups of patients, showing that mucosal injury can occur on the tracheal tissue adjacent from that suction notch, but at a rate up to about 23%. But the majority of that trauma was limited only to erythema. The remainder were some minor lesions and ulcers. Another study who also noted that lesions and ulcers can occur noted that there was no evidence of necrosis or even extubation stridor. In fact, meta-analyses conducted to date have not associated subglottic secretion drainage adverse events like these to more serious events. So there hasn't been any identification of increased rates of reintubation, increased rates of mechanical ventilation duration, no evidence that shows that it has an impact on length of stay or mortality. So as Dr. Khanna noted, the modality preference seems to be that intermittent, while other studies say that rates of injury are independent of suction modality. So the jury is still out there. But of course, more data is needed while we emphasize safe care as we've discussed. But of note, SSD is still supported and recommended. And here's why. As Dr. Khanna showed, lots of evidence shows that it does decrease the rate of VAP. But if you don't believe it or you haven't seen it for yourself, don't worry, you're not alone. A perceived lack of benefit or not believing that SSD decreases VAP is a primary reason to not use it. But one recent meta-analysis noted that when you do use it, you have a much less likely risk of VAP compared to those who don't have subglottic secretion drainage. But sometimes the research isn't enough, because if you haven't seen it in your own practice, you haven't seen it on your units or your patients that you've been, you're not alone. It's important that, we believe what we experience and what others that, we trust tell us versus what maybe, research is showing that we haven't seen for ourselves. That's natural. But before disregarding completely, let's reflect on what we've learned earlier. If the average adherence rate of SSD is about 50%, of course the impact of subglottic secretion drainage on VAP may be specific to your facility or what you've seen in your experience. If it doesn't replicate the adherence rates of the research, of course we are not going to see the same impact. So what's the point? The point is that subglottic secretion drainage is only as good as the application. So if we're addressing a lack of belief with the evidence, let's emphasize the importance of adherence. So it's really a catch-22, but it's really important if you're considering implementing, or maybe you already are implementing SSD at your facility. So again, just looking at the evidence and kind of bringing up that if your facility's average, there may be some room to grow when it comes to that adherence. So what can we do as an action to help institute, help implement, and help adhere to that task? Well, the first thing, pat yourself on the back, because we're here doing it right now, is educating ourselves on SSD technology, its impact on VAP, and then of course, how important adherence is, and how some of the barriers are fairly straightforward, and hopefully you'll be able to address those barriers, assess your adherence rate at your own facility, and challenge them. Educate others, show them the evidence, show them how much that adherence rates will impact. It's really, a hand in hand. Not only do you have to have the technology, but also utilizing the technology consistently and safely. Being a role model for good adherence rates for all of evidence-based practice specific to VAP and ventilator-associated events. And then, of course, volunteering to be a local champion. So, teaching others, a lot of peer-to-peer education is also important too. But again, just kind of using that positive peer pressure to help encourage others to learn and to use this appropriately. And again, I will turn this over to Dr. Khanna to conclude the session.
Thank you, Katie. It was very, very informative, and I'm sure the audience appreciates a real how-to of real bedside implementation and the skills involved with successful management of subglottic secretions. I'm going to end this now, and I always like to bring my seminars and webinars to an end by showing this slide. It is my salute to all of you and to all of us who are dealing with this pandemic or working at the front lines. I think the numbers are increasing every day, but we have to hang in there for each other and do the right thing and stay safe, keep ourselves protected, and keep ourselves such that we can do the best job for our patients. Next slide. And yes, I always bring up this slide as well. If my 6-year-old can wear a mask, then hopefully most of us can. Thank you very much, and I'm going to turn it back over to the organizers and take questions afterwards.
Thank you very much, Dr. Khanna and Dr. Bull, for a great presentation as always. Before we go into the Q&A session, I want to tell the attendees that, as I said at the beginning, this event has been accredited for nurses, EMS professionals, and respiratory therapists. If you want to get your CS certificate, you need to go to the URL on screen, saxtesting.com/init, and you will see there how you can register on the test site. You will need to complete an evaluation form, and once you're done, you will be able to print your certificate of completion if you're a nurse or an RT. For EMS professionals, the certificate will be mailed to you. Support for this activity has been provided by Medtronic. And finally, you will see, next slide, please. You will see this recording of this session will be offered to you in about 10 days to 2 weeks on initiatives-patientsafety.org. This on-demand version will be accredited also for nurses, RTs, and EMS professionals. With that, I'm going to start the Q&A session. So I'm going to ask Dr. Khanna and Dr. Bull to be here with me. The attendance of this event has been
show the problems of the high vol. Oh, can you hear me? Can you hear me, Fernando?
Yes, I can hear you.
We can, thank you.
Okay, can you repeat that question one more time, please?
Yes, I can. Yeah, we can hear you. Yeah, go ahead. Yeah, the question is there any current practical use of a high pressure, low volume cuff in critical care?
Yeah, so my short answer is no. There is, to the best of my knowledge, there is no real clinical applicability of that sort of cuff in current critical care practice. I showed you the problems associated with that kind of cuff, and I wouldn't necessarily recommend any particular use that kind of cuff.
Thank you, Dr. Bull. Are the long-standing tracheal cuff sizing guidelines still accurate, or are there any updates?
I will let Dr. Khanna speak to tracheal tube sizing. Dr. Khanna?
Yes, guidelines are still accurate. There are no recent updates to the best of my knowledge, and what we are using is standard, pretty much standard based on the guidelines that have been set forth.
The next question comes from Santiago, and he's asking, is there any in vivo studies which compare different types of cuffs? Any of you?
I can take that. Again, there is a huge you know, library of data when it comes to both in vivo and non-in vivo studies. To the best of my knowledge, there is nothing that I know of other than the material that I presented. Obviously, if you take a deeper dive into what's
We do not want to exceed 20. And again, there's definitely some discussion in the literature of continuous suction because the vocal cords can close even with the endotracheal tube, and of course with the tracheostomy, but even with an endotracheal tube, the vocal cords can close enough around the endotracheal tube to kind of create almost a vacuum. And so there is some anecdotal concern regarding continuous, but again, the research is really there's a paucity of data, and there's an important it really emphasizes the importance of looking at the manufacturer's guidelines and speaking to the provider and your facility to see what's best. But if you are using continuous, it is less than. So I apologize if there was confusion there.
In the same direction, how much suction pressure is too much while using continuous suction with an SSD tube?
So again, less than 20. So that's very, very low. And again, coupled with the expectation that drainage is going to be very scant. I know for a lot of nurses where we're used to using higher pressures, that can seem like not a lot. But again, if we draw back on our A&P anatomy and physiology, we really can understand that continuous suction can, again, from an anecdotal perspective, create that vacuum, and then it can eventually rest or cause kind of a pulling of that tracheal mucosa. So we want to be very careful. So that's why it's very light, continuous, less than 20 milligrams of mercury suction if you are going the continuous suction route. If you're doing intermittent, you can go anywhere between 100 to 150 milligrams of mercury. But again, you really want to consult the instructions for use for your particular device, because every device has its own different nuances. So please consult that, and please consult the provider as well.
Learning is repetition, so sorry for second question of the same. Now we have this one, very interesting. Somebody's saying we use subglottic suction all the time, and Michael is saying the problem is the ETT subglottic line fails after a while, usually due to a combination of thick mucus and blood clots. Any suggestions to keep the line clear?
Yeah, absolutely. Again, I hate to sound like a broken record, but definitely check with your provider, your facility guidelines, and even the manufacturer guidelines. But generally speaking, a small bolus of air and or a small bolus of normal saline should keep that line moving and at least not occluded. With the most important piece, though, is that when you do insert a small bolus, particularly of normal saline, we always reconnect the suction at safe levels. Do not use a syringe. And speaking as a nurse, I know we clear all sorts of occlusions with syringes all the time from IV lines and everything else, but this is really different, and this is why I emphasize this, is we may be tempted to attach a syringe and try to pull it out, but the levels from a syringe are just too great and really increase that risk of mucosal trauma.
Dr. Khanna, do biofilms develop to a significant issue on the outside of an endotracheal tube?
That's a good question. Yes, more data to suggest that they are prevalent on the luminal surface, but doesn't mean that the outside of the endotracheal tube, at least the part that's exposed to the flora of the respiratory tract, that there is ample evidence to suggest that would also accumulate a biofilm after a while. But some of the images that I showed are from the luminal surface, and there is more evidence to suggest that the luminal surface is more involved with biofilm development.
Okay, we still have 2 minutes, so I'm going to ask a couple of more questions. Very timely question, Dr. Khanna. Are there any studies that study the issues being observed with COVID patients and the biofilm that's being observed?
That's a great question. So there is definite evidence to suggest that COVID patients have secondary development of pneumonias, likely ventilator-associated pneumonias, especially because these are the patients who are going to be on mechanical ventilation for prolonged periods of time, average time durations 2 to 3 weeks, with an actual reluctance or to perform a timely tracheostomy. So they are a perfect, and lots of sedation, lots of paralysis as well. They are a perfect setup for ventilator-associated pneumonias. Whether there's any studies looking at the specific nature of the biofilm, I think it's a great study question. I haven't come across any papers so far, but I'm sure you're going to find a whole slew of multi-drug resistant organisms and in the biofilms in COVID patients.
Well, it is the top of the hour, so to be respectful with everybody's time, I'm going to pass it to our organizer, Tracy, so she can conclude.
We'd like to thank our speakers for presenting our webinar today, and thank you, Fernando, for hosting. We'd also like to thank all of our attendees for attending today's webinar. To obtain your CEs, please go to saxtesting.com/INIT. This is a safe site, so you can go on that site to access your CEs. Please make sure you register at the site and complete the evaluation. And the CE for the live event will expire on November 3rd, 20th. And with that, thank you so much.
Tracy, please add no HTTPS before the link. Thank you.
Right, so just go to saxtesting.com/INIT and put that directly into your browser. We'd like to thank everyone for attending today's session and have the great rest of your day.